Dear colleagues, my name is Nuna Yezadan. I'm the director of Armenian Eye Care Association, and I would like to welcome you and will start to represent Malan Akna Ophthalmological Center in Yerevan State Medical University Ophthalmology. The department organized ACP Grand Rounds and the first meeting for this year. And for the last year, we had a lot of this kind of meetings to represent the interesting cases which were presented by our neuro specialists and discuss them with their army American colleagues. And taking into account the interest in the professional field, we continue this project. And I would like to represent our guests who will have the discussion panel. And next to me, we have Ada Hovakimian, who is a doctor of medical sciences and Yerevan State professor at the Department of Ophthalmology, Yerevan State Medical University, head of the Department of Inflammatory of Cornea after Malayan Ophthalmological Center, Armenian Eye Care Project Fellow. So from the United States, John Havanesian has joined us from USA, and Jay Parikh and Matthew Wade. So let's start with John, presentation of George Ovansian, who's a fellow of the American Surgeons Association, member of the Harvard Eye Associate, member, professor at the Jules Stein Eye Institute, University of California, a vice president and board member of the Armenian Eye Care Project, and Los Angeles, California, USA. Matthew Wade, who will join us soon, clinical associate professor, Department of Ophthalmology, University of California, Irving Garvin Herbert Eye Institute, and chief of the Cornea Services and Ophthalmologist at the Veterans Affairs Hospital, Long Beach, California, USA. And for the first time has joined Jay Parek, MD. So I would like to represent him. He's a co-founder of Eye Care Consultation of New Journey, chief of the Cornea and External Diseases and the North Medical Director of the Research Institute of St. Joe's System, and New York Eye and Ear Inflammatory of Mount Sinai clinical associate professor of ophthalmology and a few ophthalmological and charity member, founder and member and director. And I would like to mention the Allergan the opinion leader and New Jersey Eye Care Consult co-founder and expert and Nordic Eye Pharma expert director. Nice to meet you that you joined us. And I'm sure that is representing the new and interesting clinical cases, and their discussions will be very, very useful for the auditorium which has joined us today. And I would like to mention that our you can write down your questions via Zoom as a question Q&A session. And now I would to Anna Ovakimian, and please, she is going to read the pre-test questions which were prepared, and you should answer to these pre-test questions before this meeting and after the meeting, so we can start the discussion of the interesting things which we learned today. Thank you very much. Hello, dear colleagues. Let me once more say thank you for the Armenian Eye Care Project and for the Malan Ophthalmological Center, with the especially to the Hofsat Miroyan and our colleagues from the United States who spend their time to participate with us for this discussion and, of course, giving us their priceless advices. And so we would like to make also the participants. And let me first of all read the questions, which are going to be about today's two clinical case presentations, which will be represented by our clinical residents, Shoshana Manukian, and then we will do them in the end. So the first question, treatment approach for ocular rosacea is as follows. Tetracycline antibiotics, tetracycline, doxycycline. Second, fluoroquinolones antibiotics like moxifloxacin or levofloxacin and others. Topical steroids for antiviral drugs. and fifth, eye hygiene and lubricants. So we will give you a few minutes to think and then march. And after this, we will start with present with the next question. We also see that we have the answers. So we will wait for a couple of minutes and then we'll continue. And so this format is presented for the first time, and the main goal is to see about the participants, especially the clinical residents, before listening to the clinical cases, what is their knowledge and how they will answer, and then check the answers after the presentations of the clinical cases. So this is one of the requirements for the Ministry of Health and the National Institute of Health. And the second question, what are the characteristic features of the rosacea keratitis? Most commonly affects the lower part of the cornea. Second, corneal sensitivity is decreased. Third, keratitis has an infection's origin. And fourth, and let us continue with the next and the third question. In case of immune ulcer associated dacryocystitis, it is recommended to use. We are speaking about the treatment. First of all, matrix metal protease inhibitors like doxycycline, tetracycline. Second, artificial tear drops. Third, cycloplegic mydriatic drugs. Fourth, antiviral drugs. And the third question, in case of immune-associated corneal ulcers, it is advised to use A, only internal use steroids, peroral steroids. Second, only antibiotics. And fourth, only antibiotics. And third, antibiotics and systemic steroids. It is only for the oral administration. So I guess we overcome the answer question of the test position, and now we can ask to the clinic presentation of the clinical cases. And the first clinic presentation will be represented by Susanna Balian. And please, and we'll start with the definition. I would like to greet everyone for the first time, and I am representing a clinical case after Sergei Malin Ophthalmological Center of the inflammatory diseases we have applied in 2024 April 16 and the corneal peripheral ulceration, which is associated with chronic dacryocystitis. So, 69-year-old man presented to who was complaining of the redness, pain, uh, and tearing and yellowish discharge in his left eye. And in this eye's vision was 0.2 point 0.2 and intraocular pressure was normal on palpation. So with a slit lamp examination, I find a corneal ulcer extended from 12 o'clock till 6 o'clock with underlying stromal infiltration. In the next picture, we have the size of the ulcer was clearly visible with the fluorescein staining. And additionally, in this yellowish discharge, it was coming from it was a kind of a pus. And in the next picture, we can see this. And we see the video on which it is, we sees the discharge from the lacrimal point. And so you can see the discharge on this video now. As in standard in all also a corneal scarping was taken for the bacterial culture and PCR testing for herpes simplex virus type 1 and type 2 and varicella zoster virus. Bacterial culture of the discharge from the lacrimal punctum was also performed. The patient was also referred for the general and biochemical blood tests. The general blood test revealed only elevated erythrocyte sedimentation rate, while the biochemical tests, which include the rheumatoid factor and C-reactive peptide, but they were within the normal range. The patient reported being particularly healthy with only history of arterial hypertension, a preliminary diagnosis of peripheral corneal ulceration associated with the chronic dacryocystitis, the question came with which pathology we should start to treat first. So initial treatment in we included artificial teardrops 4 times daily, tetracycline ointment, eye ointment 4 times daily, and doxycycline 100 milligram tablets twice daily. So the following day, the herpes PCR results they were negative. So after 4 days, the patient's condition worsened. The ulceration increased in size, and it enlarged this clog. Right? And it's coming from the across to the center, and the micro ulcer became a macro one. And this was confirmed by fluorescence staining, and so you can see this on the picture. And the discharge from the lactum punctum persisted with the same intensity. A few days later, microbiological tests were ready, and no microbes were detected from the corneal scraping. So it was diagnosed immune keratitis ulceration. And but from the lacrimal punctum eye discharge, we find out Staphylococcus aureus, and the following treatment was prescribed for the anti-inflammatory effect: Tobrek, tobramycin eye drops every 1 hour, amoxicillin 500 milligrams 3 times daily for 7 days for dark cystitis, for 3 times daily for 7 days. And for improvement the epithelialization, the patient was prescribed autologous serum eye drops every 2 hours, insulin eye drops 4 times daily, and fluorometholone for eye drops 3 times daily. Artificial tear drops continued 4 times daily. Tetracycline eye ointment at before bedtime. Doxycycline 100 milligram tablets once daily. And despite of the patient was an elderly patient, we made a decision to prescribe a systemic corticosteroids and prednisolone for doses 40 milligrams with the decreasing regimen. And 1 week later, azathioprine was started first at 50 milligram daily, then increased to 100 milligram. Of course, the liver and blood results were also under the control. Alongside the pharmacological treatment, amniotic membrane transplantation was performed, and after 10 days, the clinical improvement was achieved. And so, with the colored with fluorescein, and 10, 20 days after, the ulcer significantly reduced in size. One and after 1.5 months after starting the treatment, we had the complete epithelialization, and there was no ulceration, and we had a mild scarring, and new vessels were there. The patient was prescribed FML eye drops 3 times daily, tetracycline eye ointment, doxycycline for 100 milligram, and artificial ear drops 4 times daily. So the patient was referred to the ocular surgeon, and after stabilization of the corneal, the patient was referred to the oculoplastic surgery department for ductal cystorhinostomy. 10 days after the surgery, we see the conjugal oil is clean, was clean, and the cornea. And in the end of the surgery, we had a mild scar with newly formed vessels and no recurrence observed. And then the remaining medications, after 6 months later, the corneal scar had significantly disappeared, and the patient was using only artificial tear drops. So on the next slide, you can see the before the treatment and after the treatment, the condition of the patient's eye. And thank you for your attention. Thank you.
Very good case.
Thank you so much.
Very good case, very good story, and really nicely presented. And some of these patients obviously can be very sick and can have a corneal perforation. Sometimes it can be bilateral where both eyes are affected. And sometimes these patients need to be admitted to the hospital, for intravenous therapy and intravenous immunosuppression. But I really, really enjoy what you did, and the outcome is just so beautiful. Of course, infection was a concern, but inflammation here is really the sine qua non of what's happening here. And I'm really impressed with this case and how you took care of the patient. The before and after pictures are almost not the same person. So really, really good job, and really maintaining the ocular surface in good health with the amniotic membrane was good. Maybe for the future, punctal plugs, artificial tears, and using steroids here judiciously, obviously, is very important. Sometimes these cases can go very much south where there's a perforation and you require a tectonic graft, and those cases sometimes don't do as well. So luckily, because of your expertise, this patient did very well.
Thank you so much, Dr. Parek. This case is challenging in terms of that some people maybe would treat it differently. First do dacrocystorhinostomy and then treat the ulcer. We personally decided to go first with ulcer treatment, but meantime giving antibiotic orally for kind of preventing worsening of dacrocystitis. We were lucky that it did not get infected, but it could have. So I just wonder if you would treat differently. Would you first go with the surgery and then treat the ulcer? Or you agree with us that we decided to treat first the ulcer and then refer for surgery? So what's your opinion on this case?
I think you did a great thing. You have to treat the immunological basis of what's happening here. Obviously, it's something systemic. The dacryo is more local. So you took care of that too without going to surgery. So I agree. You sort of calm down the body. You put the patient on steroids. You modulated the immune system, and luckily that led to a good outcome surgically later on. So I think you did a great job here. I have one question here because this is a great open forum global. We're hearing more and more about insulin drops. I learned more and more about it actually on Instagram and on CareNet and some of the other social platforms that we use here in the U.S. But what has been your experience? Maybe John and colleagues on the call can certainly opine. What has been your experience using insulin drops, the purpose of it, and how you've taken care of these kind of patients?
Anna, you've had some experience with using insulin drops. I think we talked about that last year. You want to share yours to start with?
Me?
Yes, Anna Hovakimian. And by the way, I want to congratulate Dr. Belian on a very nicely done presentation. Very, very
Excellent.
well.
Thank you so
Very
much.
well prepared, and you presented all the salient points nicely. Well done.
Thank you so much. Actually, we are very happy with these insulin drops. We haven't done any study comparing if we didn't use it, what would have happened. But usually we start with serum tears. And if it's not helping, we add insulin. But this case was severe enough, so we just decided to go with everything was possible to enhance the epithelialization process, like, oral doxycycline for MMP, reasons, matrix metalloproteinase inhibition, or topical tetracycline, and for epithelialization enhancement, the serum drops and insulin. I would say we use it a lot. It's already like maybe 2 years. I learned about it from CareNet. I'm happy I'm participating. Thanks, John, for giving this opportunity already 15, 16 years ago. And my colleagues are also on this great forum. And it's an opportunity for us to stay updated, kind of what's going on all the time. Besides, joining the conferences in US or in Europe, but also it's kind of something every day you learn what's new. So I would say it really helps. Although we use in combination of so many things, it's hard to say if we didn't use, would it heal? I don't know, but we felt comfortable. If we use insulin drops, then probably this will heal faster.
You have the question with the same logics. So if we have a why when you decided to go for the risk and prescribe the oral glucocorticoids? Thank you for your question. Yes, the peroral administered steroids are always risky, especially if the patient age is more than 55 or 60 years old, especially in female patients who always have some doubt and have the aseptic necrosis of the bones. And other issues and diabetes, hypertension, and peptic ulceration. But if we are working with the immune-associated ulcerations, and the experience shows that the immune ulcers cannot be treated locally. It is proved in many scientific researches you should always prescribe the peroral immunosuppressants for treatment of immune-associated ulcers. And the patient's weight was 60 kilogram, and we just go to the risk. So in the 4 days, the reduction, and we added immunosuppressants like azathioprine or Imuran. And 4 to 6 months in this kind of cases, we continue this weak immunosuppressants. And we are also doing the blood tests, so checking the ALAT and ASAT and general blood tests. Or in case of the appearance of leukopenia or thrombocytopenia, we will reduce the dose, or we will change it with the cyclosporine group of the drugs. It is impossible to treat the immune-associated ulcers with only topical drops or injections of the diprospan. So in any literature, if you will review it, you will see that there is a peroral immunosuppressant that is necessary in case of this kind of macro ulcerations. So we have one more question. How the insulin drops are prepared? And insulin, for preparation of the insulin drops, we have a specific scheme. And you can write me via the Facebook or the social media, and I will give you the description of how we prepare it.
Going back to one
Yes.
question now, of course, if the patient was febrile, had a fever of 102 or 103, sorry, Fahrenheit, but had a fever, was toxic, had a white count, and so forth, obviously this patient would be admitted, and then and had an abscess, for example, in the lacrimal sac, then perhaps you have to take care of the infection and what you did immunologically with the inflammation. But I think given the fact that he was sick, but not incredibly sick and did not need to be in the hospital, I think you did a good job. And obviously these kind of patients need to be looked at daily, because the risk of perforation is always very, very high, right? And if he rubs his eye or he falls or whatever may happen. So I think there's a great case for the spectrum here of treating infection, inflammation. Sometimes you do one versus the other, which is what you did, but sometimes you have to treat both. And because he wasn't toxic or systemically very sick, I think you did a terrific job.
Matt,
Thank you so
anything to
much.
add?
Thank you so much.
Dr. Wade, anything to add?
I agree. This was an excellent case and very well presented. My question is, what would you have done if there had been a corneal perforation? What would your approach have been?
If it were a very small, tiny perforation, we could have put a cyanoacrylate biological glue. If it were a little bit bigger one, maybe covered with amniotic membrane. I would never say cover with conjunctival flap, because this is an immune disease. You don't want to bring the conjunctival vessels and enhance the immune, process, inflammation. So no conjunctival flap surgery for this case, but amniotic membrane. And if it were a huge one, probably a patch graft, maybe.
Yeah. A good point also for everybody in the audience listening is that dacryocystitis chronically is a really common condition, and it should be, what it's doing is continuously dumping bacteria into the tear film. Yeah. When you see patients in preparation for cataract surgery, it's important to check every patient for chronic dacryocystitis, because it is not always obvious. And so you kind of need to press on the lacrimal sac and see if you get reflux and what comes out of the puncta when you do that. Because if you do cataract surgery on a patient with active chronic dacryocystitis, there's a greatly increased chance that they'll develop endophthalmitis, and it's entirely preventable. So that's not related to this case, but your treatment of antibiotics removed bacteria from the equation here so that it did not further complicate the immune process that was happening in the cornea. So you did the right thing. You intervened where the most vision threatening condition was first, which was in the cornea, and then addressed, secondly, the surgical approach. Great. And I think you have another case, right? So we should
Yes,
probably.
we have the second case. Thank you so much. And President Shoshana Manoukian, please present the targeted note.
Yeah. Dear colleagues, first, thank you all for being here. So I'm happy and thankful for this opportunity to present here. So my today presentation is rosacea keratitis, especially typical cases, diagnosis, and our treatment approach. Rosacea is a chronic inflammatory condition that affects both the skin and eyes, primarily involving the central face and the area around the eyes. It's a complex disease with non-specific and variable ocular signs. Prevalence up to 10% of population, ocular manifestation more than 50% of patients, and in 20% of cases, ocular symptoms appear first. Onset between 30-50 years, more common in fair-skinned individual, but it can be missed in dark-skinned individual because the redness is just harder to see. The disease is typically chronic with remission and relapses. So severe mechanisms are considered in etiology. It's thought to be resolved for combination of abnormal immune responses. So we have overreacting immune system and inflammatory process and dysregulation of blood vessels. So we have vascular dysregulation, immune dysfunction, microbial factors. So it is common to see rosacea with Demodex blepharitis, and maybe Demodex mites may directly or indirectly trigger rosacea. And environmental and lifestyle triggers. So rosacea patients tend to have heightened sensitivity, environmental triggers like emotional stress, spicy foods, and even there are some recent publication suggested that cinnamon in diet can trigger rosacea because due to the fact that cinnamon dilates vessels and promote inflammatory process. So the most common signs of ocular rosacea are chronic blepharitis and meibomian gland dysfunction. Also, ocular symptoms vary and may include dryness, itching, blurry vision, frequent styes and chalasia. Here are some patients' pictures who have rosacea. So here is the patient, a man with rosacea who have rhinophthema, which is a thickening of the nose due to enlarged sebaceous glands and fibrosis. There are some telangiectatic vessels on face along the eyelid margins. So we see also cylindrical dandruff at the base of lashes, which is characteristic of Demodex mites. Corneal involvement occurs in around 1/3 of cases, and it typically involves inferior part of the cornea, and we can see corneal opacification in inferior cornea, stromal edema, neovascular vessels, and some small, tiny punctate infiltrates. Here are some cases, typical rosacea cases. You can see also lipid keratopathy as a complication of long-standing vessels because long-standing vessels lead to lipid deposition in cornea. Also, there is a case, rosacea keratitis with flectanular lesion before and after treatment. We see just tiny vessels and mild scarring. Rosacea can cause episcleritis, scleritis too, and regarding uveitis, we will talk about it later in the end of my presentation. Today we are presenting two atypical cases of rosacea keratitis, where we have 360-degree neovascularization, so entire cornea being involved in the process. So the first case is a 17-year-old male presented to corneal department with complications of blurred vision, foreign body sensation, tearing, photophobia, and persisting for the past 3 days. Here on the photo, we see hyperemic eyelids, eyelid thickening, crusting. Also, this patient has Demodex blepharitis, so we see cylindrical dandruff at the base of lashes. And here is the cornea, where we can see that we have almost 360-degree neovascularization. And the dark field maybe vessels are not well visible in this photo, but it's involved entire cornea. And also we have corneal opacification, which was covering entire pupillary regions. And neovascular vessels. So in left eye, we see two flectanular lesions. Treatment was started with lead agents to address meibomian gland functions, tea tree oil as a treatment of Demodex blepharitis. We know that in USA you have started widely to use X10Y eye drops as a treatment of Demodex blepharitis, but in Armenia, only tea tree oil is available. So oral doxycycline, 100 milligram twice daily to reduce inflammation and improve meibomian gland functions. Topical tetracycline for the same anti-inflammatory effect, just topical. Topical steroids every 2 hours a day to control corneal inflammation and suppress neovascularization. Preservative-free artificial tears and psychoplegics. So after 3 weeks of treatment, we see that corneal neovascularization had significantly regressed. Stromal edema is gone, and just a mild haze left in the central part. And about visual acuity, it was hand motion, and now 20/100. And a patient maintains on preservative-free artificial tears and mild steroids. And the second case, a 22-year-old female presented to corneal department with bilateral ocular discomfort, blurred vision, photophobia, foreign body sensation, tearing. And here we can see it. This is an interesting case, I think, because we have both typical and atypical rosacea keratitis. In the right eye, we see that inferior cornea being involved. So we see stromal edema, neovascular vessels, some small, tiny punctate infiltrates. And in the left eye, we see 360-degree neovascularization, which extended into central part, and stromal edema in entire cornea. So, and also this patient had dermatological signs of rosacea. Maybe in the left eye, it's look like stem cells deficiency, but in complex with dermatological signs, it's rosacea keratitis. And treatment, so the same treatment were applied as well. And after just 1 week, we see that markedly improvement of corneal neovascularization, cornea almost clean, and there are some tiny vessels barely visible. So this is just eyes before treatment and after. And finally, I want to present a case where we have ocular rosacea associated with anterior uveitis with iridocyclitis. So patient had multiple recurrences during 23 years. And 5 years ago, she presented to corneal department with signs of iridocyclitis. So we see the photo of patient. We see that she had rhinophthalma, redness of face, and also in cornea we see severe infiltrates, intensive stromal edema, neovascular vessels on in inferior part, and also signs of anterior uveitis like posterior synechiae. So it's reported very well, same treatment as we do with rosacea keratitis. We want to report about it because we have many patients with rosacea, and rosacea is common in Armenia, but this is the only case in corneal department in 23 years where we have rosacea, ocular rosacea with uveitis. And management of ocular rosacea during remission is really important. It's including eyelid hygiene, preservative-free artificial tears, topical tetracycline in severe cases, omega-3 fatty acid for anti-inflammatory effect, and also for improvement meibomian gland function, avoidance of non-exacerbating factors, and oral doxycycline reduced to 25 milligram daily for an additional 3 months to prevent recurrences. Thank you very much.
Thank you.
Anna, any comments?
Yeah, I would like to mention that the last slide she put the uveitis case, upper part was after treatment and below was before, so the red eye became white. But I would like to add that in uveitis cases, we have also used posterior subtenon injections of betamethasone a couple of times. So on top of oral stuff and, tetracycline, etc. So the uveitis required a couple of injections. So this was really interesting because I was following these patients since 2001 when I was back from US, and then, multiple recurrences, and all of a sudden with uveitis. This was interesting, and we didn't find any report of uveitis associated with ocular rosacea in literature. I don't know, maybe we'll look again, but there wasn't any report.
Do you think she has two diseases, or are they related?
It's tough to say, but I ruled out everything that's possible for anterior uveitis. I mean, everything was on the list, and everything was negative. So maybe related, maybe not. I don't know, but it was just interesting. Every time she was recurring with corneal, signs, and this time with also synechia, and she got also thinning of the cornea. That was interesting. I have a couple of cases of rosacea keratitis. I don't know if you see that in US, but sometimes it looks like keratoconus, but it's not. It's like thinning,
Yeah.
And last time, I think I showed you a couple of cases when you are in our clinic, the ones that had also thinning. This lady had also, I don't know, multiple recurrences lead to stromal lysis by time. Well,
yeah. Dr. Manoukian, you presented it very well. It's rosacea is a tough discussion because it's there's more we don't know about it than we do know about it.
Yes,
and
definitely.
So you presented it, Dr. Manoukian presented it very well. So any other comments, Matt or Jay?
No, excellent. I always, whenever I see uveitis, I'm just really grateful that I have smart people like you to refer things to, so I don't have to take care of it myself. I do have one question though. Have you ever used ivermectin for either Demodex?
Yes. She should have mentioned it. She just said we don't have XMY, but we don't have ivermectin either. Okay. Unfortunately, the tea tree oil is the only thing is available, but it works. It works.
Okay.
Yeah.
Thank you.
I would agree. Great case. Whenever you see a flectennial, obviously the differential diagnosis is important, but the two ones you don't want to miss would be tuberculosis. So getting the patient a TB test is important because that could be systemic and that could lead to secondary uveitis. And then chlamydia. Chlamydia is also a big one. So, but again, great cases. The ocular surface is incredibly hot. No pun intended. And I think as a world, we're learning more about the role of, Demodex and blepharitis and rosacea. And sometimes, like you said, maybe some uveitis, either coincidentally or the patient just immune compromised on the ocular surface and so forth. But again, great case. I think I'm going to send all my patients to you now from New York.
Thank you so much. It's a compliment. Thank you.
It would be nice to see if we could get a compounding pharmacy in Armenia to make eye drops of lotilaner, because lotilaner is a very commonly used veterinary medication for Demodex, right, and it is the active ingredient in Xdemvy, which has been really stands out as being cidal. It kills these Demodex. It basically eradicates them, and most patients who end up having recurrences after treatment, it's either from reinfection or another part of the body that gets infected, we think, because it is quite an effective drug. And we're only beginning to learn how it modulates diseases like rosacea, because, until you have a treatment, you tend to ignore a disease. So
Right.
it's a very interesting time for all of us that we're learning about how this disease works.
I asked the company guy at ASCRS at Exhibition Hall. He said we can order from Amazon, the generic one from Amazon. So we'll see.
Is there a generic that is manufactured, and is it affordable?
He said it's in Europe, not in US. In US, you have XDMY and you have, a Lotte, how you say, excuse me, Lotenier.
There's
Yeah.
only one in the US. It's Xdemvy. We pronounce it Xdemvy.
XDMV.
XDEMVY.
VY,
in
XMV.
English.
Yes,
But
but he
it's
said,
lotilaner. It's just lotilaner eye drops.
yes, that's what he said is available in Amazon and very cheap, and probably our patients can order it. So we'll see. We'll start finding it out
It would be
if we
very
can do
interesting
it.
to see your perspective on that, because you have a lot of expertise in identifying these patients and in following them. You have a good localized population, so there's opportunity for your residents and fellows to publish papers on how this works.
Right.
So
Because we used to order these, wipes called Blefadex, Clearadex, from
Clearadex.
Amazon. So patients are kind of used to order this type of things from Amazon. We need to find out that we'll be able to, order this medication as well. We'll see and let you know, and ask our Armenian company maybe if they can prepare it. So we need to ask.
Yeah, great.
Because
This was a very
it's
good
so
conference.
common. It's common, very common.
This was a very good conference. I hope everybody learned something from it. Looks like we had a good number of participants, and I hope we get all the residents and fellows, and other international learners who are visiting Armenia and learning to participate in these conferences, because they're really good teaching. And I do believe we record them. Yes.
Yes, we do.
We record.
We record them and also have on Open or on our other platforms.
Open, yeah. Learn with Open, which is more for pediatricians, but available for anybody.
On DM tool, and also on our DM tool, we have diabetes and ophthalmology.
Fantastic.
That's very important, just to have access to these kind of very interesting cases and discussions, because this opportunity is not available during conferences.
What I love about what you
Are
did today,
especially that
yeah,
case.
what I love about what you did today is you presented something very common, which is great learning in both cases, the peripheral ulcerative keratitis and the rosacea, as well as dacryocystitis. But you presented unusual cases of them, so that we learn not only about the unusual, about the rare, but we also learn about the common. So for folks who are beginning in eye care, this is great learning. For folks who are advanced in eye care, this is also great learning. So this was just very well selected cases that you picked here.
Thank you.
Congratulations.
Thank you.
On good cases.
Thank
and
you.
good.
I'm happy you like these cases, and probably young doctors learned a lot, hopefully.
Art? We have a question, it seems that, can we cover that before we?
Do I need to go through this?
So is this
Yes.
anonymous attendee says about the omega-3 use.
The question was about the omega-3 use. It is proved or not. It's a very, very good question. The use of the omega-3. To be honest, if I'm how much did I know, and in some researches, it is not proved with 100% that it is effective. But if you will ask me separately, I was in United States and participating a few weeks of ACARS conference, where it was representing that advantage, the types of omega-3, which is the FDA approved, and this is the one we are effective for the treatment of dry eye syndrome. And I drove this omega-3 and with fish oil drug, which is used, and we can order it via Amazon, and it is very affordable. And a lot of ophthalmologists are saying that it is effective to improve the function of the some fatty glands, and many people believe.
The question is, do we all believe that this omega-3, fish oil, all this help with meibum gland function? I am saying it's not 100%, statistically proven, but everyone believes that it does some good job. Do you agree with that, doctors?
Yes. Yes.
Yeah,
Yes.
you do. So you advise your patients to take omega-3
Oh, yeah.
in tough cases.
And now, first of all, I would like to say thank you to all of the presenters, and which were a little bit stressed, but they had a very good presentation. And Professor Anna Vakiman, and of course our mentors. It was a very interesting format for discussion of this kind of cases. But before ending our session, I would like to ask once more to fill in the tests which we gave you in the beginning, and we will have these questions on the screen.
US colleagues, thank you so much.
Thank you for having us.
Great job.
Great job.
Waiting you in September.
Looking forward to it very much.
Thank you for all the participants and all our colleagues and our honored professors and Armenian Ophthalmological Project as usual. Thank you for organizing this meeting. Good luck, everyone.